I think we have time for some questions, but I'd like to bring one point up. I think that these were excellent talks, and the access issue is there, and we have to solve that. But even if you have access, I think Walter's data shows us that we have a huge thing to do in our communities in educating everyone, patients and providers, to make sure that people get what in there to be screened and vaccinated. That's a big thing to overcome besides access. So there was a question back that way. Yes.
I want to say something that may be controversial to some people, but I feel it very, very strongly. And that is, we've massively overscreened women for cervical cancer. And I think we're finally getting better because more and more people are adopting evidence-based standards. But we have to deal with that, because that money that we are using both in the private sector and the public sector to screen women who don't need to be screened will go a long way to paying for what is very, very, very expensive, which is to get those women, as 15 or 20%, who will not be screened. It's very expensive to get them, and we do not, at CDC, we have enough money to pay for 8% of the eligibles. If CDC has a broad, they have educators and outreach workers and people in these remote communities, and it's hard to get those women in. It's a lot easier to get women in who've had Pap screening recently, 4 times. We could also use that money to pay for more immunizations. So we really have to deal with over-screening.
And I think you bring up an excellent point about the percentage of women who won't come in and that increases the need for vaccination. And as a GYN oncologist, I see a lot of people who are over-screened in my area. So, Joan.
My population, they've had a tubal ligation, so they won't come back in. They're menopausal or they're infertile. And so that's documented in our NCI collaborative work. But we also have to say that what's obvious in this room, and that is that OBGYNs are part of the problem. I'm an OBGYN, and that they want the patient to come in every year, and we have to have the patient come in every 3 to 5 years, not every year. And we have to figure out how to fix that, because the HPV test is good for 3 to 5 years. And so we have to be honest with ACOG, and we have to change the screening interval. And HPV every 3 to 5 years is cheaper than an annual Pap.
I agree with everything you said, and I just want to add to it from a system standpoint and building of infrastructure as it relates to healthcare reform, and that is we've got to have a system in place where we really do take advantage of the electronic health record and the data that can potentially come out of an electronic health record. If you look at other countries, such as Denmark and such as Finland, they moved to the 5-year intervals over time. They looked at their data. They had registries. We tend to not want registries in this country, but we got to figure out a way to develop registries plus protect people's privacies and make people feel okay about the fact that we've got to look at the data, both the process and the outcome data, in order to figure out how to move the dot towards eradication of cervical cancer and also towards prevention of other diseases.
I think it's maybe just a little more subtle. It's absolutely true that there is no medical rationale for annual screening in any age group. But we're not trying to keep you from seeing your doctor.
Right.
We tell our people they should still come in. We just don't want them tested with things that are fundamentally injurious to them if they're done annually. And so the goal is to make the visit worthwhile. We're not trying to keep them out of the office, and we don't. Our mammography rates have gone up dramatically over the period of time that we were converting to 3-year cervical cancer screening intervals. It doesn't mean that you don't come see the doctor. It means that the doctor's smart enough not to hurt you while you're there.
Right, and I want to add to that, there are so many preventive health assessments that are really supposed to be done, and it's age group driven. And ACOG really has a really nice monograph that kind of details what you're supposed to be receiving in terms of preventive health care throughout the various age groups. That's what you should be coming back to your physician or healthcare provider for on an annual basis, and it may be even more frequent than annual if you really are going to provide the preventive health care that is really being promised, but is not being received by people in this country.
Yeah, just a brief comment. I agree that over-screening is one issue, but under-screening is another issue that's at the same table. So over-screening is definitely a concern for AHRQ and for other federal agencies, and that's something we have to work on. But under-screening, and especially disparities in under-screening, are a great issue. So the self-reported data that you alluded to, of 15 to 20% of women not being screened annually, is actually an underestimate and a large underestimate. If you apply what I call a Rauscher adjustment to that deals with problems with specificity and sensitivity of self-report with respect to medical records, you're going to find out that white women, maybe about 75% of them are being screened according to guidelines, pap smear screening. And then when you start talking about Latina women and you start talking about African American women, you're going to get down to about 60%. That's a large disparity, and that could account in many ways for some of the deaths that we're seeing from cervical cancer. So I agree that we are over-screening, but at the same time we have to keep our eye on the under-screening that's happening and the cost to minority women.
Thank you. I was going to add to that point and refer back to Joan's point earlier about what we're really struggling with when we're trying to do this in North Carolina is how to locate those women who've not been screened in the last 4 years. And we've gone to housing, we've gone to 211, but trying to figure out. Go ahead,
But
Joan.
Medicaid knows, because Medicaid paid for the tubal that caused them to not come in. So we just need a list of everybody who's had a tubal and go find them.
So actually, I have on my list here of deliverables that do we want to consider, HPV testing and Pap smear at the time of tubal ligation, at 65 years of age, at the time of CIN3 treatment. Right. So just focus our efforts. I'm trying to get us to focus and make some clear recommendations from this panel. Walter?
It's harder than making the appointments available. There is a group of about 10 to 12% of folks that actively don't want to be screened, and it is extremely difficult. For a while, I was spending evenings doing PAPs if we could get people to take the appointments who hadn't been screened in more than 5 years. And I spent several evenings with 12 appointments that were filled and no one came in, even though they took the appointment over the phone. The only way you get to these people is if there's somebody in their internist or family practitioner's office who is like an English bulldog with a burglar's ankle in its teeth when they come in for their hypertension or their hypercholesterolemia or their diabetes or their whatever their other medical problems are, and gets their screening done. And I can prove that that works. We've done it, but it is extremely expensive. And I can't figure out how that's going to happen in the private sector until the reimbursement changes to drive it.
One more question, maybe?
We keep talking about that woman who leaves the hospital after their delivery of their last child and is never seen again. And the last time they're educated is at the time of their discharge paperwork. And there are many public health movements that are going into that discharge teaching, which include, but is not limited to, rubella immunization and the new Tdap immunization. And I would like to add to that a box on every person's postpartum discharge orders that says, what was your pap smear during your pregnancy? What is your follow-up? Their Medicaid will be gone when they show up for their 6-week postpartum visit. Their colpo has to be done before that visit, which means that you have to have it scheduled at the time that the patient is discharged from the hospital on the way out the door. And those are the patients that we can at least, that's one group that we can start to capture. Because yes, how many of them said, oh yeah, I did have an abnormal pap in pregnancy, and then you don't see them again until they have a large fungating cervical lesion. So I thought that was one place that we can capture it, is at the time of that postpartum discharge appointment making follow-up. Colpo is the most important thing you can do to protect yourself and your baby and live long enough to see that kid get raised.
Just one last comment. I mean, clearly the issues are extremely complex, and we've got macro policy recommendations and also the micro policy recommendations. And I personally have heard a lot of different suggestions that I think are perfect for beginning interventions to see what works and what does not work. And I just wanted to make that particular comment as we close this particular session, because everything that people have said has been valuable. And we're looking at flip sides of the coin in terms of screening, over-screening in some populations, under-screening in others, fragmentation of our healthcare system, and things that need to change overall, such as, and I agree with you, contraception needs to be over the counter.
And maybe vaccination and at the time, HPV vaccination at the time of discharge. Yeah, or, yeah. Thank you very much for this excellent panel.